The last time we met, can't remember whether the law had passed or not, but anyway, we now have in California, for 38 million people, the End of Life Options Act, which in other places is known as the Death with Dignity Act. This is a tremendous step forward. And all of you who helped, who contributed, we've sent over $9,000 to different organizations that have been promoting the law. Thank you very much. For some reason, I am filled with anxiety about how to implement this law. It's not my responsibility, not our responsibility, but it seems to me very important that at least those of us in San Diego know what the law is and how to access it. And that we get enough doctors so that people can be referred to them. And even if we don't help all the 1 million plus people in San Diego, it's very important that our members have access to the law if they need it. And as you know, the law is for terminally ill people, people who are judged by 2 doctors to have 6 months to live. There's a waiting period, there's 2 oral requests, 1 written request, a possible psychological evaluation. So there's a lot of bureaucracy involved in the law. And so today, we have 2 speakers who will help us with this. On my left is George Eighmey, who was here before in May, when we were looking at, is the law going to pass, how it's going to pass, what are our other options? And we still have other options, such as the final exit network, which we talked about in the May meeting. But this law passed in Oregon first in 1994, the first time in the United States that such a law happened. And then it was implemented in 1997. And at that time, Compassion in Dying took charge of how it would be made accessible to people in Oregon. And George was the first person to oversee this operation for the first 12 years of its existence. So who would know better than how to help us get this law passed? Not only that, but he was very active in Sacramento and recognized for his contribution to getting this law passed. So I would say we have the world's expert on how to do this here in California. But we're not finished, because we do expect in subsequent meetings to have other people from Washington State, from other hospices in places which have a law, and doctors locally here to help us figure out how this law is going to work for us, because that is the bottom line. Our other speaker is Dr. Glenn Panzer, who is medical director of Elizabeth Hospice, but who is speaking for himself as a hospice physician. It's going to be very tricky, I think, and very important that we have some kind of cooperation with hospice, because we all want to access hospice care, but we all, not we all, but most of us do want to access hospice care. But we also want to know that we can check out when the time comes and have a peaceful death. And whether these 2 things are compatible or not, Dr. Panzer is going to help us understand. So I'm going to turn the microphone over to George Eighmey, and he can tell us what happened in Oregon and a few other things. It's helpful to stand up. I think I can make more eye contact.
Okay, thank you, Faye, for this opportunity, and thank you all for showing up. Appreciate this, and I'm very, very proud to be here in California and part of the passage of the End of Life Option Act. First, a couple things. If I take a photograph, is it okay? Sure. Okay, I'll do that. I'll do that later. Anyway, some of the things that making laws and sausage should never be shown to the public. And in this particular case, I was involved starting last year in drafting California's End of Life Option. The senator who sponsored it, who was the Senate Majority Leader in California, Senator Bill Monning, actually was the one who started it. And then Senator Lois Walt came along, and then later Assemblywoman Eighmey. But Our first thing was we were going to use Oregon's model. Oregon's law has been the model in Washington, Vermont, and every other state that has sort of tried this. And the first thing that we ran into was that California is different. And so we said, okay, what are we going to do about those differences? And the reason I'm even talking about this is because I'm going to get into the implementation, and California is different there as well. The law that we had to do here in California not only was the Oregon model, as Faye outlined the sort of the necessary steps that one has to take. We had to add some things. First of all, some things were easily added and didn't make any difference. In Oregon, Vermont, and Washington, we call the lethal dose of barbiturates medication. They don't like that term here in California. It's drugs. Okay, call it drugs if you want. So we call it drugs. Lethal dose of drugs in California. That was easy. Then came certain things like, well, what about language barrier? Because there's a huge Hispanic population in this state, bigger than any of the other states that we're in. And so we have translators. There's a translator's provision in the law. And that person has to be independent. They have to be, they can't be part of the medical facility. They can't be part of the doctor. They have to be somebody outside. And they can't be a family member who could theoretically coerce this person and say things that weren't true. So we really crafted that very carefully. Then there was the provision with, well, we don't know if it's going to work in California. So we want to put a sunset in there, that it ends after a certain period of time. Somebody came up with 20 years, I came up with 3, we compromised on 10. And so 10 years, after 10 years, the law will expire. But we're confident enough that at the end of 10 years, there will be sufficient data out of California that there will be no problem in eliminating that sunset and continuing the law as is. Because I think now California, the latest, it's not 38 million, it's 39 million. 39 million people in this state, and if you extrapolate from the data out of Oregon, Washington, and Vermont, that means on average there will be 1,000 to 1,500 people a year that will be getting the prescription or the medication. And there will be approximately 800 to 900 people a year who use the law, actually take the medicine. So those numbers are huge. If you realize that in the state of Oregon, 18 years, we're just short of 1,000 total in 18 years. And that's how many there's going to be in 1 year here in the state of California. Not this year, because it's, it'll be, and probably not even next year, because the law is not going to go into effect until 90 days after the end of the special session, and that may be in April, May. We don't know when the special session is going to end. So that wasn't a compromise. The other compromise that was a biggie, because I am a advocate for limiting the number of barriers somebody has to access to the law. And so in Oregon, we sort of generalize statements and stuff so that we could have some flexibility as to things. But here in California, they wanted more specificity. And one of those was one that I objected to, but then reluctantly came around to accept. And that was the 48 hours prior to one's intent to take the medicine. They have to sign a document that says, I intend to take the medicine within 48 hours. Well, I said, that's another barrier, that's an intrusion. But then I thought, wait a minute, what are they going to do if the person doesn't do it? Who cares? We went along with that one as well. And there's a couple others, but overall, it is the Oregon model. And if implemented properly, it will work. It does not include everyone, and as I've told Faye over the years, I am a strong advocate for safeguards and guidelines to be in the law. And I think that's important to show the public that it works, that there are protections, that we're not any abuses, there's no coercion. And after we get a tipping point, I don't know, 10, 15, 20 states, at that point, it may well become part and parcel of medical practice. Thus, no different than when you go to your physician now and you've got cancer and he or she says, chemo, radiation, no treatment, this or that. And we weigh that physician's decision and recommendations. So someday, but we're not there. We need the data, we need the information to prove to the opponents of the law that it is working and that it is working flawlessly, as it is working that way in Oregon, Washington, and Vermont. So to do that, though, in Oregon, and I'm going to tell you what I feel has to be done here in California as well, as far as implementation goes. Compassionate Choices, when I was with Compassionate Choices of Oregon, and prior to that it was called Compassion in Dying of Oregon, we knew that we had actually 3 years. We didn't know we were going to have 3 years, but we did have 3 years to set up a program. And the reason was in 1994, when it passed by 51 to 49%, it was litigated for the next 3 years in the federal court system. And it wasn't until the second passage in 1997 by a 60 to 40% margin that we knew we had the law and it was going to be used. So we had that time in order to say, what are we going to do? How are we going to get doctors? How are we going to get pharmacies? How are we going to get hospice? How are we going to do all of these things? Because let's face it, the first doctor to do it in this state, the first pharmacist to do it in this state, the first hospice person to be asked to do that in this state, it's their first time. And they have no idea what to do unless we start educating. Compassionate Choices, I just read some stuff that they did, and they're setting up a podcast sort of educational outreach program where they're trying to try to educate people about the law and how to use it, but we still need a facilitating organization. We knew that in Oregon, we knew that in Washington, we knew that in Vermont, and they're all there. The facilitating organization, what does it do? And that's what I'm going to talk about briefly. First of all, the organization is going to be a nonprofit. It has to be in order to get charitable donations. It has to have as its mission education, facilitation, and that's what we did in Oregon with Compassion in Dying. You have to recruit board members, advisory board members, because you're not going to get any money until you get some nice names on there. The first thing I did was I went to Governor Barbara Roberts, I went to my senators, I went to rabbis, I went to priests. I even had one priest for a while that was on the advisory board, which was rare. But I had 3 rabbis, I had some politicians, I had doctors, I had people across the state that were well known. And that impresses donors, let's face it. So you got to do that. That allows you to tap into friends, neighbors' mailing list. Get out your Rolodex. We used to call it Rolodex. Of course, now they're not Rolodex anymore. Totally something else. They're all here. They're all on this thing. And if I lose this, I'm gone. So you contact these people by social media, by mail, by whatever, by face-to-face, to raise funds to help the organization. I put together a budget in California for just this area, for instance. And I came up with, to do this for next year, it would cost about $80,000 to have a half-time person on the phone and training some volunteers and answering questions from physicians, having cold calls to physicians, having cold calls to pharmacies, having cold calls to the hospices, set up educational outreach programs so that you can get out there and educate the people who are going to be very instrumental in doing this. Furthermore, you've got to educate the public. In my first 3 years as executive director in Oregon, I had on the average 3 to 4 speaking engagements a week so that I could get out there and tell people about the law, because the ignorance is everywhere. For instance, even one of my, a supportive doctor, I said, first thing I'm sitting there and he's talking to this audience and he says, well, you have to swallow 100 pills. No, you do not have to swallow 100 pills. And so I had to explain very carefully, because I didn't want to antagonize him. I just simply said, well, doctor, there are 100 pills, but we separate the capsules and put the powder into 4 ounces of water now. Oh, is that what you do? So these are the things that you have to educate people about. What do you do if you can't swallow? What if you have a feeding tube? What happens if I've got Alzheimer's? What happens if I got dementia? All of these things have to be answered honestly and straightforward. The saddest part of my job used to be telling Alzheimer's and dementia early stage, no, you'll never qualify for the law. I'm sorry. When you're mentally capable, you're physically ineligible. When you're physically eligible, you're mentally incapable. And so it was sad, but we had to do it. To be honest, this is what has to be done. And okay, so you need this type of operation going on, and you need somebody that's willing to do that in the greater San Diego area, or even the limited San Diego area. Then
we are. We are, yes.
Yes, I know. And then you have to start recruiting and training volunteers. And I have offered to come down. I had a training program where we put together training on the law, training on active listening, because active listening is the only way you're going to get people to feel comfortable with you. And if you don't know what active listening is, it's a form of listening carefully to what the person is saying and responding and bringing out the answers from them to what they want to do. And then it's also the process. They have to know the process. And the number of questions I got from people, family members, how does one die? Do they lose bowel and bladder? These are very open things that we have to discuss. We can't hide that stuff anymore. And so I knew I had the experience, and so I was able to do that and talk to them about that. Then I'm willing to come down and do some training of volunteers to help them through the process. I'm willing to talk to doctors. We've got outlines of how do you talk to your doctor? How do you talk to the pharmacist? Who does the cold calling? I would go out. I had a medical director, Dr. Nancy Crumpacker, who was fabulous. Without her, Oregon's law would never have been implemented. She was an oncologist. In the first couple of years, she was a practicing oncologist who actually did some prescribing. But then she retired, and she decided that she would be our medical director and made these calls to doctors, just simply saying, Dr. So-and-so, I know you from this meeting or that meeting. You may not know that I'm with Compassion in Dying of Oregon. I'm wondering if you would be willing to be the second opinion doctor on a case with this other doctor. And if we got the second opinion doctors, we knew within a few years they would be prescribing doctors, because they would find out that they were providing a service for their patients that was what their patients needed. And that was the compassion and passion that they had. You need to prepare documentations for the rules, how to talk, not only how to talk to your physician, but here is what I used to have pamphlets on, this is what you need to know as a patient. And here, I'm going to give you a checklist of what you have to do, so that they would check it off, and it was much easier to go through than simply me telling them. Telling people, they remember only 10% of what you tell them. And especially if they have a terminal diagnosis, once that is in there, they're in the 5 stages of grief. As you know, Kubler-Ross's denial and anger, and generally when they first called us, it was anger. It was in that anger stage. Until they get to the acceptance stage, the last step in the grieving process. That is where they then are ready to go forward. And so we have these forms, and it's necessary, and they have to be simple. They cannot be complex. You cannot be talking about medical terminology that's going to be over their heads. Most of these people are highly educated, by the way, but they're still, the medical terminology is not something readily understandable. So we did that. We prepared these patient guidebooks, physician guidebooks, volunteer and pharmacist guidebooks. I would call pharmacists, and sometimes when I was in Eastern Oregon or Southern Oregon giving a presentation, I would just go into a pharmacy and say, may I speak to your traveling pharmacist? Why the traveling pharmacist? The traveling pharmacists are not necessarily affiliated with CDC or the Walgreens and all of the biggies where they have policies against allowing their pharmacists to prescribe or fill the prescription. But if you've got the traveling pharmacist, he or she is generally independent. And they'll say, oh, sure, I'll do it. I'll do it. And I can remember to this day, I went into a little town in Prineville, Oregon, population 10,000. And I walked into the pharmacist and I said, hi, my name's George Eighmey, I'm blah, 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 blah. And I said, if I have a patient here that needs prescription under Oregon's Death with Dignity law, would you fill it? He said, of course I will. Never had a pharmacist in that city before, and there we have it. Now he fills them for all of these little towns around there, so it's great. In the beginning, we had about 5, 6 physicians. When I left, we had over 1,200. We had 4 or 5 pharmacies. When I left, we had over 700. And it takes time. That's why in your first couple of years, the numbers of people who are going to have access to the law is not going to be as great as I predict in the future, but you have to build this up. And now, when I left, 50% of our recommendations came from hospice. 25% came from physicians or physician groups. And the rest came either from people who knew, or they were family members or something like that. Or from my educational outreach program. In the beginning, 0 recommendations from hospice. So my biggest hurdle was to tell hospice, we want our people enrolled in hospice. 95% of all the people who use the law in Oregon are enrolled in hospice at the time of their death. That is double the penetration of hospice in the whole state of Oregon, which is about 47%. We are one of the highest penetration states in I don't know how many percent here in California, but we are one of the highest participants in hospice in the United States. But when it comes to death with dignity, we are almost double that average. And that is incredible. And the reason we started encouraging people to get into hospice, we knew that if they got into a quality of care that was acceptable to them, they would find that even though they have the option for death with dignity, their quality of life was acceptable and they didn't need it. We've never said it's either or. It can be both. And once that happened and the word got out that I was doing that, hospices started coming on board. And I'll even tell you the little story about Providence Hospice, which is the Catholic facility in Portland. They ordered all of their hospice personnel never, ever to give out our number or to even mention it. If a patient asked for death with dignity, they had to have a psychological evaluation immediately because they were suicidal. that changed. As time went by, they changed the policy about 2 or 3 years, and they said, well, you can write their number down on a piece of paper. Then, a couple of years later, they started handing out our brochures. And years later, some of those same hospice personnel were present when people took. Because hospice people, as far as I'm concerned, are angels on earth. They are the most wonderful people I have ever met in my life. And they care for their patients. And they become part of their lives because they're during this period in their lives when it's very intense. And so now, throughout the state of Oregon, I understand there's over 100 hospices in this San Diego area. We've only got 60 in the whole state of Oregon. But they all participate to some degree. Being present, helping out, making the referrals, and that's what has to be done. These are just the steps I'm outlining that have to be done so that this is implemented properly in this state. If it is not, I'm afraid, and just like Faye has said, I'm very concerned that it's great that we have the law, but it's not great if nobody can have access to it. And I'm going to be reaching out to all of you and just simply say, get in contact with Faye and the organization about, is it possible that some angel will raise enough money to have this operation in this area? And I'm willing to come down free to help train them and give them my time, because I think it's that important. Compassionate Choices, as I understand it, is educating and willing to educate, which is good, which will save some of the necessary outreach. But I understand that they're giving out an 800 number, and I am getting calls from California already that calling the 800 number, it's taking 2, 3, 4 days before they get a response. And they have another program called Doc to Doc, where they're allegedly going to have a doctor who's going to talk to doctors here in California to help them walk through the process. The doctors that they're going to be using are, as I understand, don't quote me on this, a couple in Oregon, and they're going to just be overwhelmed. They're just going to be absolutely overwhelmed with questions. And so we need somebody, we need organizations throughout the state. If we can only start in this area, okay, we can only start in this area. I'm hoping that we can start in other places throughout California, because 39 million people, and if you talk about the fact that 1,000 will be calling, I averaged about 100 calls a month, and most of those were not people, they just wanted some information. It boiled down to we averaged about 20, 25 patients a month through the pipeline. Well, here that's going to be horrendous. You're going to have 250 to 300 going through the pipeline. And so there needs to be an organization that's willing to handle that. I'm hoping, I'm going to reach out to Compassion and Choice and ask them if they would be willing to give some funding. They've raised a great deal of money in California, $17.1 million on the Brittany Menard story. And they just got $2 million from George Soros. So we don't have that kind of organization. We don't have that kind of money. Death with Dignity National Center, even though we're a national organization, we spent $5 million in Massachusetts and lost by a vote of 51 to 49%. We spent a lot of money in Vermont to get it passed. And so we raised it during the campaigns of trying to get the law passed in the various states. So there you are. And I think we're going to have questions afterwards, right?
Yeah.
Thank
That's
you.
very encouraging, George. Also very scary that we have all this work ahead of us. so that we can all take advantage of this law that we have fought so hard to get here. And now, one of the angels from hospice, I hope, I don't know, Dr. Glenn Panzer, who is medical director, as I said, of Elizabeth Hospice, who many of us use here, our loved ones have used. But he's speaking for himself. Dr. Panzer.
Thank you. And in case you thought I was texting, I was taking notes and preparing what I was going to talk about. That's why I was looking down at my phone. I wasn't texting. I can tell you that. Yeah, one of the things with, how many of you have had loved ones who have used hospices? The hospice, for most of you, is a great way to end your life, not end your life, but finish your life. With hospice, one thing with the goals of hospice, and probably why it was 0 to start and then it grew, was in hospice we look at that hospices want to help people live out the rest of their life with the best quality of life they get. That's our goals in hospice. Most hospices don't want to prolong life, but then again, most hospices, they think the hospice community feels that you don't want to end life prematurely or early. And so it's that they want to do a balance. They want a balance between prolonging life and ending life, and not ending life prematurely. I look at hospice as to me, when people come to a point in the road where they have less than 6 months left to live, and there's a point in the road where they want either to push quantity of life or to push quality of life, and they choose hospice because they want to push quality of life, they're not going to take all these extra meds to prolong their life as much as possible. One of the things I know, when I took a course up in Washington about 7 or 8 years ago, an ethics course, and they kept talking about the death with dignity law. And being a hospice provider, you think that you've given your goal in hospice is to allow people to die with dignity, to die with comfort, and to be comfortable when they pass. And you're looking at, and we also look at it not helping people die, but helping people live a good life for whatever time they have left, and you give them the best quality of life we can give them for the time that they have left. So that might be some of the reasons for the reception that hospice might have gotten up north. And he was talking about numbers. I heard somebody say that we have as many people in San Diego County. If you're talking about going up to the Riverside border, going up to Camp Pendleton, going east into the mountains, as the state of Oregon, or maybe with San Diego County as well as maybe Lower Riverside County.
San Diego County has about 3.3 million. Oregon last year was 3.5 million.
3.9.
3.9.
So,
All you Californians are moving up.
It's true.
We have only maybe 50 hospices. We don't have 100.
Oh.
now I'm told by the statisticians in my hospice that there's about 100 hospices in San Diego County.
Oh,
Yeah. I also was mentioning to my colleagues here on this table, and also to Mitt, is that I'm told that one of the biggest hospices in the country that taught hospice to the country and taught hospice to the world, and is no longer with us in San Diego County, San Diego Hospice used to have all their meetings here at the a lot of their big meetings at the Scottish Rite Temple.
We weren't invited. We were not
You
invited.
were not invited.
No, we were not.
So there might be some ghosts from San Diego Hospice here in the in Scottish Rite. But yeah, to me, they were a great hospice. They took care of people. They had a big heart, but their heart sometimes extended beyond what they were allowed to do by keeping patients on longer than what the federal government felt they shouldn't have done. But they were a great hospice. Everybody there had a great heart, and they taught hospice to the country. They taught hospice to the world. And so I want to respect them. And here in the Scottish Rite Temple. The hospices, there was a state organization called CHAPCA, California Hospice and Palliative Care Association, that had its annual meeting last week. I'm told they had one of their sessions was a well-attended session, probably highly attended session, was about the new law. Some of the discussion is most of the hospices are going to support people who choose to end their lives with this new law, because they want to be there. If they're with the patient, they're going to want to be with the family to help support the family get through this. The problem, one of the things they came up with is there's going to be 4 different approaches that different hospices are going to have. And one of them is some hospices are going to embrace the law and go all out to support the law and support what's going on. There's going to be hospices that are going to collaborate and work with the families, stay with the families, support the families in whatever decision the patient wants. Sometimes you're going to have families who are against what the patient's decision is. So part of it is having a discussion with the patient and families from the hospice perspective from having a discussion with the patient and families so they can all be on the same page when this happens, rather than having that conflict at the time of death. So the second tier is support, not embrace, but support and not give up on the people who choose to take their lives towards the end of life. The third one is hospices that are resistant to the law, but still, with resistance, go along with what their patients want to do. And then there's going to be some hospices that don't want to be involved with patients who follow their wishes with the law. So there's a variety of 4 different types of hospices. There will be a variety. I think right now the hospices are trying to figure out, as everybody in the state is trying to figure out how this law is going to be implemented, the hospices each one is trying to figure out how they're going to respond to patients who come to them and say, this is what I want to do.
How will we know the difference? How will we know which one to go?
You'll probably know over time which ones are easier to work with than others.
Bad news.
Yeah, some of it is one of the things I wanted to talk about is when I saw, I think recently, UC Irvine, I don't know if anybody saw that there was a video of a debate that they had about death with dignity law. And with that video, the person who was pro death with dignity or compassionate choices or whatever you want to call it, is he gave an example of his father and how his father, he wished he had something so that help his father die because his father would not want to live the way he did. And to me, that was a misinterpretation of the law because there's two different things. There's suicide, there's assisted suicide, and there's euthanasia. And he was looking at it as helping his father die rather than, giving his father some medicine. But his father wasn't clear in mind to know what he was taking.
Yeah, that's euthanasia.
That's euthanasia. And in respect for my wife, I'm Jewish. My wife works for Jewish Family Services, taking care of Holocaust survivors. So one of the things I worry about is, which the person who was talking against physician-assisted suicide was saying that things can go into other steps. So what I wouldn't want is people to assume that, to say, well, my father wouldn't want this, so we're going to help him die. Because that's euthanasia as opposed to, we're going to help him die, but he has to know that what he's doing. No.
Yeah, if he knows what he's doing.
If he knows what he's doing.
You must be competent to.
Yeah,
He
he
must
must
be
be competent.
Yeah.
He must be competent.
He
If
can't
he
have-
injected
he can't have
him
dementia
or
or-
with he was unconscious or unable to communicate and he did something, then that would be euthanasia.
Right.
But,
That's what I'm.
okay,
Yeah.
so if the father was not
on the same
able
page
to
as you
communicate,
are.
yeah.
Yeah, so you have to be able to communicate, because you don't want people to feel that I'm going to take somebody's life because their life is not of value. Yeah, it has to be the person choosing to take their own life.
That's the law.
Yeah,
That's the law.
that's the
I mean,
law.
that's, well,
It's
Yeah.
law everywhere.
Yeah, it's
Everywhere,
a
in
law
Europe,
everywhere.
here and everywhere, yeah.
yeah.
Yeah, but part of what I was getting at is the person who was arguing in favor
Yeah.
of it used his father as an example, which he shouldn't have.
That's
Yeah.
Competent, yeah.
Yeah, but with hospices, they want to work with the patients and their families. Hospices do palliative sedation also, so when you can't get somebody comfortable, you'll give them medication. You'll give them medication to make them sleep if you've tried everything else to make them comfortable. And so hospices are so they've developed standards or processes on which they'll go through in dealing with this. They're going to develop processes in helping people with physician-assisted suicide. And in developing the processes, they're going to be wanting. Most of the hospices are not going to want to give up on the people and say, well, if you want to do this, I don't want to take care of you. Most of them will probably be supportive of taking care of the person as they do something, but it might be the process of what do they do at what point in time with the person. I'll hand it off to.
Okay, I'm just going to make 3 comments, Dr. Panzer. One is, I think, as George well knows, suicide is not in the law. In fact, it specifically says in all the laws in all the states that this is not suicide for insurance purposes or for any purpose. So it's
Right.
referred to as physician aid in dying. As a psychologist myself, I think of suicide as an impulsive act by somebody who does have alternatives but doesn't see them right then and there. Always violent, always alone, and this is not what we're talking about at all. So we'd rather have the word suicide out of the vocabulary. And as far as those countries that permit voluntary euthanasia, the person must be competent, which is quite different from what you described when a person gets palliative sedation as directed by the doctor, not necessarily by the family or the patient. When the doctor decides whether the patient's competent or not competent. So even though, I'm sorry, I've had this debate many times with hospice people, doctors should never help people die, but when my patient is in intractable suffering, I will help them die. They may not know about it, they may not consent to it, but we will make them comfortable with palliative sedation. So I find that contradictory.
Basically, with palliative sedation, it's when patients are uncomfortable and they say, you know, and they want to be made comfortable, you'll let them, you'll give them medication to help them sleep, and they don't look at it as helping them die, but make them comfortable, and death could come, or death will come when death comes. It's not giving them something to bring death on. It's the same thing with pain medication, helping with pain and suffering, and you're giving pain medication. Sometimes the goal of giving the pain medication is for comfort, but sometimes the side effect of that is the breathing stops.
Okay. I don't want to hold this debate myself, so thank you very much. Both speakers have been very helpful.